Hello, everybody. Welcome to Healthcare Studies 100 Introduction. I want to take this chance to just go over the four major themes that you will see in this course and that we'll revisit many, many times. And once you know these and you're familiar with them, you'll see them in the articles and the videos, and you'll start seeing how so many things that initially appear to be separate and unrelated oftentimes come back to these central pillars in healthcare. The first one, and we're seeing this in such an intense way in 2020, has to do with this sort of disparity between curative medicine and treatment on the one hand and public health and prevention on the other hand. And under this broad term of healthcare, these two sort of subsets exist. There's hospitals and doctors and nurses and pharmaceuticals and surgery and all these things that we do with you or to you or for you under the banner of curative medicine and treatment once you get sick. And that's where the bulk of the money goes to. That's where the bulk of the attention and the fame and the glory and the television shows and all the attention that comes in healthcare, the vast majority of it goes to curative medicine and treatment. One way to think of it is downstream. So once someone has been pushed in or fallen into a river, curative medicine treatment is the rescue to get them out, to get them well again, to heal them, to take care of their illness. And again, in medicine, of the $3.5 trillion we spend every year, 98% of it goes to treatment. There is another part of healthcare called public health, and public health tends to focus a lot more on prevention. And prevention doesn't get near as much attention. Although right now in this pandemic, people are thinking for the first time, for a lot of people maybe, for the first time, they're thinking so much about prevention with hand washing and masks and other protocols and distancing and stay at home and quarantine. Those are all public health methods of prevention. And people don't tend to think of those until you have to. And so this is another thing about healthcare is that when medicine works, if you have cancer and we treat you and we cure you, oh my gosh, I mean, you love your clinicians, you hug them, you run 5Ks for them. There are buildings, money flows, fame and attention, Nobel Prizes. When public health works, nobody notices. It's invisible. So when the vaccine you get against polio when you're a child prevents you from getting polio, there's never a moment in your life where you're just so emotionally ecstatic that you go back and hug your pediatrician or your pediatric nurse. This is the dilemma in healthcare, which is when medicine works, it gets more money, more fame, more attention, more glory. When public health works, it becomes more and more invisible and taken for granted until a crisis erupts. And this gentleman right here in the book about him, his name is Maurice Hilleman. He is one of the most famous vaccine researcher and developer probably in human history. He worked for Merck, and he developed the bulk of the pediatric vaccinations that most of us get when we're young. And nobody knows his name, and nobody knows how famous he is. But everybody knows Dr. Oz and Dr. Anthony Fauci, and I'm glad that we know him. But Maurice Hilleman deserved the Nobel Prize for Medicine and never got it. People like Maurice Hilleman who developed vaccines, now we're having an appreciation for them. But for most of history, vaccine developers get a little attention or no attention. Vaccines are so successful that at this point in time, we have this weird phenomenon of people who don't want to take vaccines. That's how successful vaccines have come. We've had maybe 2 or 3 generations now where people haven't seen these infectious diseases. They've never been scared by them. And now we have a growing anti-vax movement. So theme number 1, curative medicine treatment gets the vast majority of the fame and the attention and the funding, but public health is really important too. And the better we do public health, the less you need curative medicine. And it's a lot cheaper to prevent a disease than to treat a disease once you have it. And these are just examples. Needle exchange trucks, or needle exchange programs. I can show you numerous studies that show that if you have an HIV outbreak or a hepatitis outbreak because people are using contaminated needles, if you roll in a needle exchange program where I give you a dirty needle and then you give me a clean needle, if you just do that, it slows dramatically the transmission of infectious disease. And so that we should all be rallying around programs that work like that. But you ask people, do you want to fund needle exchange programs? You often get a lot of ambivalence, like, no, wait a minute, that might be good epidemiology and public health and prevention, but I don't want my tax dollars paying for people to get clean needles for their drug habits it just emotionally rubs people the wrong way. Other forms of prevention in public health, condoms and family planning, contraception, all that stuff should be really valued and appreciated, because preventing unplanned pregnancies, preventing sexually transmitted diseases from being transmitted, that should be applauded and embraced. But that mixes with people's philosophy and religion and sensitive issues like sex. And so a lot of the condoms and condom education and family planning is not universally embraced by everybody. The HPV vaccine. Yeah, if you had told people for all of history we have an anti-cancer vaccine, and that anti-cancer vaccine also prevents sexually transmitted diseases like genital warts, and it's just a vaccine, you get it when you're young and you never can get those diseases, people would be dancing in the streets. In the developing world, cervical cancer is one of the biggest killers. But you get this vaccination around 10, 11, 12. People are asking, why is my child getting this? What's the necessity of it? It's sexually related, so we don't know if we want to do that. It's public health, it's prevention, but it makes people uncomfortable. Until all of this, I say all this until you get sick. And this is a printout of a measles outbreak at UCLA. This was about, I think, 2 years ago. And all of a sudden, students at UCLA had to learn a lot of public health, because these were the places some students got exposed to it. This is where they all live. And then they had to find who had measles and get them over here in this quarantine location. And then all of a sudden you think, wow, why is measles at UCLA? We have a vaccine against measles. Measles was almost eradicated for all intents and purposes. Why are we dealing with this? This is like a historical thing. Well, it's not historical because we've gotten lazy and too relaxed about vaccines. And then these diseases come back, and then we think, oh yeah, public health is really important. And later in this course, we'll be going over this numerous times and in numerous lectures. We are all learning in a very painful, personal, hard, and brutal way that if you don't do good public health, if you suppress information, if you deny the reality, if you don't prepare, if you don't do prevention, if you don't get ready, these pathogens, these diseases do not care what your politics are. They don't care what your culture is. They don't care about your economy. They just spread. It's not even a they. There's just RNA and DNA. They don't have any intent. But right now, in ways that none of us have experienced in our lifetime, a failure of public health and a failure to come to grips with the reality of this, the mathematical and scientific inexorableness of this, means we're at home. We're doing this class online with Zoom, and we may be doing it this fall to some extent, because if you don't give public health the attention and the funding and the respect it deserves, you're going to be dealing with the situations we're dealing with now. That's theme number one. Theme number two is, I would love to tell you that love is the most powerful motivating factor in higher education and in healthcare. And it's up there. I hope it's up there in medicine and higher education. But right above love or respect or ethics is money. Money is just a powerful force in everything in life, including in healthcare. So one of the things this class will show, that if you want to have a better understanding of how healthcare actually functions, and how it functions well in some areas and how it doesn't function well in others, follow the money. The money explains why things happen. Just a famous example. These are the 5 top teaching hospitals in the United States. They're always usually the top 5. U.S. News and World Report ranks them. Sometimes they switch positions, but it's usually the same 5 usual suspects: UCLA, Hopkins, Mass General, which is Harvard, Cleveland Clinic, and the Mayo Clinic. They're great. If you get sick, go to one of these that's closest to you. In fact, rich people around the world come here to these places because they're all 5 equally awesome. Having said that, they're not the same in their culture. They're not the same in the way they do their pay and reimbursement of healthcare providers. And the way you can kind of tease that out is you look at Medicare spending in the last 2 years of life for Medicare patients. So that's a public health insurance program, Medicare. They all have the same health insurance. It's all old people, and then they're all in the last 2 years of life. So you have the same kind of demographic. You have the same stage of life, the last 2 years. You have the same insurance. So you have the same mechanism paying for this care. And you compare UCLA to the Mayo Clinic, and you realize that dying in the last 2 years of life or spending the last 2 years of life at UCLA cost the taxpayers $94,000. the same basic patient population spends less time in the hospital and has less physician visits and costs less at the Mayo Clinic. And the first thing you think of is why? I mean, these numbers should be relatively similar to each other. Well, the biggest explanation is that UCLA, like the majority of healthcare systems in this country, tends to make their pay of clinicians based on fee for service. The more services you do, the more days you spend in the hospital, the more visits you get, the more you get paid, fee for service. The Mayo Clinic and the Cleveland Clinic tend to lean towards more of a salary position, where clinicians get paid a salary for the year, regardless of how many visits they have or how many consultations they do. And so this changes the behavior. If you're paid per every Zoom lecture you give, if I get paid per every Zoom lecture I give, I'm going to give more Zoom lectures versus, hey, Rick, you get paid X amount for a class. You just got to teach the class the way you want to teach the class. But how you pay anybody for anything changes their behavior. So we have these horrible gumballs that fall down from our tree in our backyard. And we could pay our children, hey, go out and work for an hour. We'll pay you per hour. They're not going to necessarily get as many gumballs. We could pay you per gumball you put in a bucket. And my assumption is, and actually I've seen this play out, you pay per gumball, you get more gumballs picked up. Now, what does that mean in terms, what's the big takeaway from that besides the fact that money and how much you get paid and the way you get paid impacts your behavior? Got that. Well, what does that mean for the United States? Well, as you'll see in this class, this is a big theme. The US spends a tremendous amount of money on healthcare. It spends upwards of 18% of our GDP, about $3.5 trillion a year. We spend the most, and the total amount of money we spend the most as a proportion of our population, as a proportion of our economy. We spend the most in every way you want to say most. But we don't get the best return on that spending. We get decent results, but not great results. Other countries spend less. They spend less as a total proportion of their budget. They spend less per person, but their life expectancy is longer. And their health outcomes are, in some instances, as good as ours. So there we are. We're the biggest spender per capita. Here's the average, but we don't live as long, right? We have much higher administrative costs. Go talk to your doctor, nurse, and other clinician friends, and they will tell you there is so much bureaucracy, so much paper filling in, and so many forms, and so many electronic health records, and so much administration. That's part of our system because we have a much more of a for-profit element. We have all these private entities that have their own standards, their own forms, their own everything, and that's just costs more money to run all those. We spend a lot less on long-term care compared to other countries. And this is this graph that shows, gosh, we spend all that money. Well, what are our outcomes compared to France, Germany, other countries, Denmark, UK, Canada, on things like obese or overweight proportion of the population? We're the highest. Life expectancy in total population, we're the lowest. Health adjusted life expectancy, the lowest. Life expectancy for women over the age of 40, the lowest. Life expectancy for men after 40, the lowest. Maternal mortality rates, the highest. Infant mortality rates, the highest. Neonatal mortality deaths, the highest. Low birth rate, second highest. So, we're spending all this money and we get good results, but not as good as our peers, and they spend less than we do. So here comes my insult of all Honda owners, which is not an insult because I've had many Hondas in my life and I love Hondas. But this is a saying you'll see in this class a lot. We have Mercedes level health spending, but we get Honda level outcomes. My goodness. What's wrong with Honda? Nothing. Honda is awesome. Honda will get you from point A to point B with regularity and predictability and dependability for a decade or more if you take care of it and just change the oil. Go Honda. It's awesome. It's affordable. But if you're spending $50,000 and getting a Honda Accord, then you're overspending. You shouldn't spend that much. And that's what we do with healthcare in the United States. We have Mercedes level health spending per person in total, and we get these sort of the average results. Now, in healthcare, as in every sector of life, education, transportation, housing, there's three things we want. We want cost control. We don't want healthcare to burst our budget or bankrupt our family finances. We want healthcare, but we want it to be affordable. That's cost control. Of course, everybody wants high quality. Nobody's willing to take mediocre healthcare. And if you're a human being that I want to hang out with, you want universal access. You want all human beings to have access to healthcare, because healthcare is the foundation that the rest of life is on. It's like the ultimate human right. If you don't have health, you don't have anything. The reality is it's really, really hard. I'm not going to say it's impossible because individual health systems manage to pull this off. No one national health system can do this, but individual, like little regional systems, Intermountain, Geisinger, Pennsylvania, Intermountain, Salt Lake City, some of these individual ones, the Mayo Clinic can kind of pull this off. You can have cost control, you can have reasonable healthcare costs, high quality, and you can give it to everybody in your little system. At the national level, or even at the state level, keeping costs down, having super, super high quality and giving it to everybody is virtually impossible. So what's happening most of the time in most countries is they have two of these. They have costs under control, they have high quality, but then they can't give it to everybody. So they struggle. The way they do that is they just have rationing. They say, okay, we're going to keep costs down, we're going to keep hip replacement quality high, but you got to get in the queue. Access will be rationed in a line, and when your number comes up, then you get it. So they limit access. Other places have high quality, and they give it to everybody, but then costs become really hard. That's like France and Switzerland. So you can give it to everybody. It can be high quality, but then the costs get pretty tough. And you can also have cost control down. You can keep costs way down, give it to everybody, but then your quality slips. All of a sudden, healthcare outcomes are kind of scary. The hospitals aren't safe. You see this sometimes in Britain with the National Health Service. They keep costs down. Everybody has access to it, but then at the margins, the quality starts to slip. So this is the iron triangle of healthcare. You want all three, but you can only have two at one time, and then one slips. And then here's the trick question: which two does the U.S. have? Well, you know we don't have universal access, and we know we don't have cost control. Wait a minute, I thought we were supposed to have two. We don't. We have one. We have high quality of care. Most of the time, most places, we really do have high quality care. Our doctors, nurses, respiratory therapists, dentists, we have some of the best clinicians in this country, the best quality, but we don't have cost control. We don't have universal access. Okay, theme number 3. Oh, all my little pre-clinical students out there, all those who want to go to nursing school, PA school, dental school, med school, all of you students spending inordinate amounts of time in Gottwald and science centers and studying enormous amounts of science classes and organic chemistry and slogging and struggling. God bless you. Medicine is biomedical, it's scientific, it is rigorous, and it's awesome. So it's scientific. But go spend a week in a hospital or a ride along with EMTs or doctor's offices, and you quickly realize that as scientific as healthcare is, it's also wildly emotional and psychological. And I'll give you just 2 quick examples. The Cleveland Clinic is maybe one of the premier, it is the premier cardiac institute in the United States. If you have heart problems, go to the Cleveland Clinic. The doctors there were shamed and embarrassed that for so many years, the biggest McDonald's in Cleveland was in the basement of the Cleveland Clinic. And they thought it was just a bad reflection on cardiac care to have fast food in the basement. But and they kept saying to the hospital administrators, get this thing out, get this McDonald's out of the hospital, remove this and put something healthy in there. And that McDonald's was stubborn and stayed in there despite the doctors wanting it out. And then what you realized over time, and the doctors figured out, was that McDonald's brought in a tremendous amount of money, both to McDonald's and then by extension to the Cleveland Clinic. And money will cloud your scientific, pure, rational, mathematical thinking, and it'll make you think emotionally. Money makes you think emotionally. So medicine is scientific, but it's emotional. And when emotions get involved, sometimes it's a struggle to stay rational, scientific, empirical, right, and super scientific. Another one, if you go out and ask 10 people on the street just randomly, what kills more women, breast cancer or heart disease? If you say what kills more women, oftentimes you get kind of weird answers. They think, oh, well, it's breast cancer. It must be breast cancer because breast cancer is scarier. It tends to be more of a female disease. When you look at the stats, deaths by breast cancer are dwarfed by deaths by heart disease. But there's just something emotional about cancer in general. It's scarier. And when something is scarier, it skews your perception of what the actual risk ratio is or what the actual threat is. So we should be a lot more afraid of heart disease, and we should be spending a lot more resources in fundraising and public awareness campaigns on heart disease. But actually, breast cancer gets a lot more attention. There's a lot more fundraising, and it's not that breast cancer isn't worthy of attention. It strikes down a lot of women, tens of thousands each year. So it needs to be focused on, but it actually needs to be focused on a little bit less per se than the risk of heart disease to women. But our emotions make us focus more on a less likely, less risky, less threatening thing. And you'll see this a lot in healthcare. We sometimes worry wrongly. We worry more about something that's less likely to cause us a health problem, and we under worry about things that are much more likely to cause us health problems because emotions get involved. And the class's ultimate fourth lesson of all of this is that if you're going to work in healthcare, especially on the clinical side, you're going to need a lot of courage, because healthcare, it's not like other professions. And you're seeing, I think people are seeing this when you see the clinicians coming out of the hospitals in New York and Italy and Spain, and people are just drained because they are facing some of the most gut-wrenching, difficult issues and situations that nothing in life really prepares you for. Working in healthcare is awesome. It's a calling. Helping people is such a high, and we need people to do it. And it's a sacred thing. But if you're going to work in here, you have to practice self-care. You have to be aware that you're going to be drained, and your empathy is not limitless. It's tough, and that's the thing. It's just, you're seeing. I think all of us are seeing this now in ways we hadn't seen it before. Is we're seeing just how challenging and difficult working in healthcare can be. I think this little quick clip is coming up, and we can take a look at this.
It's scary. I mean, it's absolutely terrifying to be on the front lines.
We have seen the numbers, and we've seen people how sick they get and how quickly they decompensate, and a lot of us are afraid to get ill or bring it home to our families.
It definitely leaves a mark on you. I mean, I think after this, none of the healthcare workers will be the same.
When you're on a flight and they say if the flight's crashing, you put your mask on before you put your friend or your loved one's mask on, because you can't save people if you are not safe yourself. We wear our masks, like I said, our entire shift. We're constantly washing our hands, but the risk is definitely there, and it's heightened for sure.
Asking us to reuse N95s for 30 days, asking us to now maybe reuse the actual PPE that we wear. It is just scary. We advocate for our patients, and our leaders should advocate for us.
I did sign up to save people. I did sign up to try and help save people, do my part. I want to make an impact, but I didn't sign up to die.
People are risking their lives without proper armor. I mean, you wouldn't send people to war without proper armor. Like, we don't have PPE. We're going in to fight this battle without the proper protection.
It's unacceptable for nurses, doctors, like I said, any healthcare team to have to go to work and not have what they need. We want to try to help as many people as we can, and if we're sick, we cannot do that.
It's okay. I remember I was being scared. I feel now. I'll do my best not to take advantage. That's little brother. I don't want to say no to my child that I can't kiss him, but inside something eats at me that I might be exposing him to some things. It's one thing when you're protecting yourself, but now when you put your loved ones in jeopardy, that's a lot of weight to bear.
My job as a mom is to protect them. So when I make that choice to go to work and I take on those patients, and I know in my heart and in my gut that I might not be protected, and I still do it, you have that remorse to think, okay, I might be taking this home, and I'm not protecting my girls.
As a nurse, you hear all of these stories, and you see these nurses, and they're sharing their stories, and you can see it. They're tired, and they need help. And not only that, but you hear all of the stories of patients dying alone, and they don't have anybody there with them. And I just kept thinking about my family, my mom, my dad, and if that was them, I would want someone to be there, and I would want someone to want to be there. If I can help one person, if I can hold one person's hand,
if I can be there for one person, it's all worth it.
People in my state, a lot of people have a very hard time believing that this is real. When I walked into that ER and I saw what I saw, I knew, I thought this is more real than anybody can understand.
And it's so big freezers, and it's really eerie, and it's really a lot of emotions because there's bodies in there, you know. So I saw it on the news, but in person it's so different.
What we're doing right now, the way our lives are changing, it really is making a difference. And it may be small, but even staying home is helping.
The silence is kind of eerie, but also gives me a little comfort knowing that people are doing what they're supposed to be doing and staying home. And, you know, for those of us who are going to work, it can feel a little bit safer knowing that people are at home like they're supposed to be.
This isn't permanent. There's a light at the end of the tunnel. We just need to get through it, and everybody needs to do their part. And if it means staying at home and FaceTiming your family, if it means sewing masks for your local nurses and techs, you know, everybody can do something from home. Everybody has a part in this. It's not just healthcare workers. We all have a role in stopping this.
You have stopped screen share.
Take care, guys.